Cotard's delusion, The Walking Dead, A Corpse Tale. So with walking corpse syndrome or Cotard's delusion, we're going to talk about who it affects, how we can identify it, and how we treat it. We're going to also talk about the history of who discovered Cotard delusion, medical diagnosis, and what makes Cotard so different from other delusions. We're going to talk about medications and treatments, and we're also going to discuss nursing problems that are associated with Cotard's delusion and goals and intervention we can put in place for these patients. The man behind the madness. In the late 1800s, Dr. Jules Cotard described delirium hypochondriaque in a woman who was middle-aged that was describing symptoms to her family, that she didn't have any nerves, she didn't have a brain, and she believed that her internal organs were not there, and she thought herself to be made of skin and bone. And she also didn't believe that God or the devil existed. A few years later, Dr. Cotard introduced another term for a different patients, for other patients that denied their existence, and that the world that they lived in wasn't a normal world. And that was called delirium denegation, or delirium of denial. And the term Cotard's delusion didn't come about until a few years later, when other researchers were putting together investigations about these symptoms, and they used Cotard's work. Cotard delusion, or walking corpse syndrome, is a pretty rare disorder, and it's in people who believe that they are dead, that they're dying, they're non-existent. Some of them also believe that they are missing specific limbs of the body, or all their internal organs or partial internal organs are missing. A lot of them think that they're immortal. So a lot of these people don't think that they have a soul or that they even exist. Some of the researchers also believe that Cotard delusion has 3 specific stages. The first stage they believe to be the germination stage. This is where the patient starts to display the depression and hypochondria. The second stage is the blooming stage. This is when the disorder really starts to show its true colors and the symptoms that these patients are going to have. That's when they start to have the delusion of the negation, where they think that they're dead or that they're dying, or that they're not real. The last stage is the chronic stage, and this is the most severe of all the stages. This is when the patient has severe depression, they have the really bad delusions, and their whole world is completely distorted. So other symptoms that they could display, 89% of the patients have depression. They also feel guilt and anxiety, and they have a preoccupation with death or harming themselves. People who are mostly affected with Cotard delusion tend to be women. It also has a tendency for the patients who are under the age of 25 to have bipolar disorder, and it also can occur in kids and teenagers, but is more likely to occur in people who are over the age of 50. So they also, for the diagnosis and the risk factors, there's really no set criteria for diagnosing a patient with Cotard delusion. They basically have to rule out other disorders, and for these people that it's kind of hard to get an actual diagnosis, because they also usually have other mental health disorders or neurologic dysfunctions, like bipolar disorder, schizophrenia. They could also have psychotic depression. And neurologically, they can be affected by a traumatic brain injury. They could have a history of stroke or have had a tumor. Treatment is based on symptoms. So again, we're treating symptoms for these people. Most effective treatment is electroconvulsive therapy. This would also go in conjunction with the other treatments, but these patients would usually have to have about 3 treatments a week for about 2 to 3 weeks. So usually around 9 treatments, 8 to 9 treatments the patients have. And before we give electroconvulsive therapy, we want to give a muscle relaxant to make it more effective and for the patient to be able to relax. And we also don't want to do this in patients who have epilepsy, because basically what they're doing is causing a minor seizure to reset the brain. For the medications, the patients also will be taking antidepressants, they'll be taking antipsychotics, anticonvulsants. We could also give sedatives for the patients who are having the manic phase. And along with the medications, the patients need to have psycho or behavioral therapies with the ECT. Those are the patients who are going to have the best outcome, is to having all 3 therapies. So with any patient, nursing is going to play a big important role. We're going to talk about nursing diagnosis and goals and interventions that we could put in place and what we would expect for their outcomes. So for these people, they're going to be at risk for injury because of their delusions of the immortality. And we see that because they have risky behaviors because they think they're already dead or dying. Good short-term goals for them, it would be for the patient to be free of injury for at least 24 hours, especially when they're first admitted into a facility. We want the nurses and the staff to make sure they're observing the patient a little bit more closely. And we want the patients to be able to identify risk factors for injury for themselves so that they can play a bigger role in their care. Long-term goals, we want the patients to be able to explain ways to keep themselves free of injury, so when they do discharge home, we don't have them going out and injuring themselves because they're not being realistic. These patients also can have impaired nutrition because, again, their delusions, they think they're already dead, so they don't need to eat, or maybe they just have an inappropriate diet for the vampire people. A good short-term goal for them would be for them to be able to eat at least like close to 50% of their meals within a week or 2 of admission to a facility. We want to start introducing small, frequent snacks to the patients so that they have food available to them, and we also want to offer them foods that they're familiar with. Long-term goals, we want them to be able to gain enough weight to be closer to their expected weight for their age and their height. We want them to probably do a food journal because it's pretty effective in them being more involved in their care and being more accountable. So they're also going to be at risk for skin impairment, their skin integrity. Short-term goals for these patients, we would want for them to be able to identify risk factors that they have, probably within the first day of them admitting, or first 24 hours admitting to a facility. We want the nurses to assess their skin. They can use a Braden scale, a skin assessment, risk skin assessment when they're admitted. Long-term goals, we want these people to put together a plan of care to prevent skin impairments when they go home. So they're also impaired socially because of their beliefs of being dead or dying, or that they're immortal. We want these clients to be able to identify the barriers that they have for their social impairment. And a long-term goal, we would want for them to be able to interact socially successfully with other people. NCLEX style question. A middle-aged woman with a history of traumatic brain injury has stated she believes that she is dead and has no soul. She denies any other symptoms. And which disorder should the nurse consider when treating this patient? Select all that applies. Walking corpse syndrome, crazy lady syndrome, Cotard's delusion, Cotard syndrome. The answers would be A, C, and D. So all but crazy lady syndrome.